And here is part 2 of our interview with Dr. Kevin Katz, where we try to make sense of the guidelines that were provided to us, focusing on PPE, engineering controls, and the cleaning and disinfecting of operatories. Okay, thank you so much. The other piece of information that was shared with us was regarding appropriate precautions when it comes to the management of patients. And one of the issues was the need for us for a 30-second 1% hydrogen peroxide rinse. And Kevin, we're just wondering how, in your opinion, was this recommendation established, considering there's other evidence to support the use of chlorhexidine or a betadine spray?
Yeah, so I mean, I suspect that they came to this recommendation after the ADA had already put out their recommendations. So I suspect there was a little bit of photocopying that was happening on that specific one. But I think the disinfectants aren't exactly all the same. And you talk about chlorhexidine. Chlorhexidine is more of a bacteriostatic, bactericidal side, and it actually has a more prolonged effect, whereas hydrogen peroxide actually has a more rapid and does have more virucidal. And then the povidone iodine, I think ADA had actually given that as an alternative as well. So I think the chlorhexidine is because it tends to be more focused on bacteria. And if you think, you know, in my world, chlorhexidine, when you use a surgical scrub with alcohol and chlorhexidine, the alcohol has a rapid kill, whereas the chlorhexidine under the surgical gloves prevents bacterial regrowth under the gloves of the hand flora. So it's more of a sort of a longer term bacterial suppressor. And so I suspect that's why they left that one off, why they didn't put the povidone iodine like the ADA. Not 100% sure. I know that there is work going on in this regard. There was the head of dentistry at one of the major hospitals, cancer hospitals downtown, had reached out and actually tried to put in a grant with me on viral load reduction in COVID positive patients with a number of swishes. So that work is definitely of interest to a bunch of people.
You know, before we switch away from these chemicals, I have a bunch of people asking about hypochlorous acid. There was a document released by the Korean group that was claiming this was the best disinfectant and everything else around it was sub to that. Any comments at all, just so I can tick it off my box?
Yeah, I don't really have a comment specifically about that, but just you know, it wouldn't just be the chemical all by itself. I think these things, as again, when I say it's 0% to 100%, and this is somewhere in the middle, remember, like, the mouth is made up of mucous membranes, there's cells there, and the virus replicates in cells. And so even if you swish, it doesn't mean that there's no more virus that's actually coming into the environment on an ongoing basis as saliva is being produced or as cheek cells are sloughed off and things like that. So this is more of a risk mitigation. It's not a risk elimination. It just reduces the viral load. It doesn't eliminate the viral load. You're not sterilizing the mouth with whatever you're using.
Thank you, Kevin. Other recommendations regarding office and clinical procedures was a description of PPE for front desk, administrative staff, and the introduction of the concept of a physical barrier at our front desk. And I wanted to ask you if you could comment, in your opinion, on how critical is the placement of a physical plexiglass barrier at our front desks?
So,
and pardon me for jumping in,
sure.
Kevin. To add to that, if I may, John, how critical is that when we're already told to have our receptionist wearing a mask? They might be wearing a surgical mask, wearing glasses, and the patient's wearing a mask. So how, throwing that into the picture, how do you feel about the plexiglass? Thank you.
Yeah, so generally, the approaches, all of these are risk mitigation strategies to prevent exposure of one person to another. And again, all of these patients, presumably your offices are screening them the day before they're coming in or asking them immediately as they walk into the office whether they have any symptoms. So hopefully the symptomatic cases are dealt with, but the asymptomatics, as we talked about earlier, is the main area of concern here, and trying to mitigate that exposure from one person to another. So the types of strategies that are invoked there are spatial separation by 2 meters, physical barriers to put something between those two individuals, or personal protective equipment. And so, you know, I won't comment on the document, but I'll tell you the way that I operationalize this at the hospital. I think you can do any of these things. You don't have to do all of these things. So if you put up a plexiglass barrier and the clients are physically separated from the reception desk staff, and, you know, not with a big hole that they can talk through, but there's a barrier and somehow the sound is able to transmit. You know, maybe it has some sort of a grill on it, or maybe it's positioned in such a way so that the hole is not directly between the two of them and things like that. If you have a plexiglass barrier, that reception staff does not need to be wearing PPE, as long as they are not within 2 meters of another reception staff who's sitting right next to them. So there needs to be physical separation between them. If there is no barrier, and you could set it up that the reception staff are actually sitting back more than 2 meters from where the clients are, and ideally, you know, not ideally, that they shouldn't actually come in close proximity within 2 meters of the person. So if they have to give, you know, fill out some forms or things like that, they sit back, and then the client puts the forms down, and then they go sit down at the waiting room, and then the reception staff takes them. Again, they don't need to be wearing the PPE. But if that's not possible, then the reception staff should be wearing the mask as PPE between them. So, you know, I think the document may sort of make it sound like everybody needs to be in everything all the time and then add all of these other components. But the principle is that you don't want reception staff exposed to other people and protecting their mucous membrane. So if there's a physical barrier, we use that actually to reduce our mask use in the hospitals, because, you know, there's a huge supply chain shortage on some of these things, a little bit less now with the droplet masks than the N95s, but still, they're not the easiest things to get. And so that's one option. The other one is just physically moving them back. And the third option would be PPE. And I think the RCDSO may have just sort of, you know, written it in an oversimplified way. But I think if they reached out to somebody like me, we could help them rewrite it so that it's more clear cut what the principles are.
Okay, thank you.
Thank you. Another item in the guidelines were precautions as they relate to the donning and doffing of personal protective equipment. And in particular, they shared the Public Health Ontario document on taking on and taking off personal protective equipment. Our question for you, Kevin, is why is it so critical to properly remove PPE following an aerosol generating procedure?
Yeah, so I mean, when you're putting it on, when you're donning it, it's all clean. So there's very little risk in that way, unless you've left this so-called clean gear out and it's actually contaminated. So assuming it's clean, putting it on, there's not any risk. Taking it off is actually extremely important, because you're assuming with the aerosol generating medical procedure that the actual gear has been exposed to these aerosols and that it's contaminated, potentially with COVID-19 virus as well. So if you look back to the 2003 SARS outbreak, there was a lot of questions about whether it was airborne, especially during these intubations and high-risk procedures. And actually looking back, I mean, there's still a little bit of controversy around that, but I think it's pretty clear-cut that a lot of those transmissions to healthcare providers related to not taking off the gear, not doffing the PPE safely. And so as you're taking the gear off, it actually is not the aerosol generating medical procedure necessarily, although again, there's some controversy there, but getting out of the gear is actually quite easy to contaminate yourself, and that's when the transmissions were happening. And so, you know, looking at this, at the pictograms, I think the really important pieces that I stress when I'm talking to physicians and nurses is, you know, and you guys do this all the time, so maybe it sounds a bit silly, but taking off the gloves. When you're taking off the gloves, you have to start off with 2 gloved hands. The first glove, you take your dirty glove and you touch the dirty glove. So it's glove to glove. You pinch it at the palm and pull it off. And then you have a clean hand and a dirty glove, and you need to go skin to skin under the cuff. Otherwise, you're going to contaminate your hands. And then when you take off the, and I should say, you start off with the dirtiest parts of your gear. So you start off with the gloves and then the gown, and you go from the back, you untie it and you stay on the inside of the gown, take it off, roll it. So you're always touching the inside of the gown, which is cleaner than the outside of the gown. And then before you put your hands up to your face, you need to sanitize your hands. And then you only take off anything on the head from the back. You never touch the front of the visor. You never touch the front of the mask. You only touch the back straps. And so you take off the visor, sanitize your hands because you're about to go to the highest risk thing, which is taking off the mask. You never touch the front. That's where you make, because remember is that you take these straps, pull it off, and then, you know, leaning forward a bit, you pull it off and then put it straight into the garbage and then sanitize your hands. So it seems like a simple thing, but as we go through this, I've done this hundreds of times with doctors now, a little bit less with dentists because the offices are closed, but actually a lot of the healthcare workers who have done this for years and years, they all have sort of, oh, type of moments as they're doing refreshers. It's not as straightforward as you think. And you don't necessarily need an expert, but having someone talk through it like I just did, and then buddying up and actually trying to do it and having one person observe the second person, it is a little bit different than you may normally have done it last year.
Steve, did you have any follow-up questions on this issue of removing PPE?
The only question that I have, Kevin, with regard to this is where's the best place to doff your PPE? In the treatment area, in a room beyond the treatment area, what would you recommend?
Yeah, it's a good question. So I guess maybe, well, yeah, I won't make any assumptions. So the gown and gloves can definitely be taken off in the treatment area. No issue. The visor as well can be taken off in the treatment area. The real controversy, I mean, they could be taken off in the hallway too. You just want to make sure that you're not contaminating the hallway and that you need to have alcohol hand rinse that's available close by whenever you're doing this, because there's multiple steps when you're cleaning your hands. The controversy in this, and maybe this was what you were going to ask me if I didn't touch on it, is where you remove the N95 respirator. If you're wearing an N95 respirator and you've done an AGMP, an aerosol generating medical procedure. And the answer for that is if you've done an AGMP and you're concerned about aerosols, meaning that you are waiting for a washout period, you know, all of those things, which the college is recommending, the only place it makes sense to take off that N95 respirator is outside of the room. So you need to leave that environment and then take off the N95 respirator. Everything else can be taken off in the environment. And, you know, in COVID positive patients, when I'm taking care of an actual COVID positive patient who's symptomatic, when I take off the gear, I need to be 2 meters away from the patient. So the head of the bed is where the head of the bed is. And then I go to the door, I take it off just by the door. And then if I'm wearing an N95, you know, now less common because, you know, I don't do intubations and things myself. If I was wearing an N95, that would be taken off outside of the room once the door is closed.
The reason, Kevin, I'm just going to expand on that just a little bit, because I know a lot of us, a lot of discussion about the reuse of these N95s in a dental office, because with some kind of level 3 mask over top of the N95, where you kind of consider, and I don't know that this is, consider the N95 as something I'm going to put on it, you know, in the morning and wear till lunch, seeing many patients and is that something, and we were basing that on the CDC document that you referred to earlier about having a non-contaminated surface, and the rationale was we were covering up the outer surface and that was going to stay with us throughout the day. Is that something we should not think about, or something that is done right is a possibility, especially with the shortage of N95s?
Yeah, so I think prolonged use of N95s in this environment makes a lot of sense, and making sure that the surface is not contaminated, probably with a visor or with a procedure mask if you have a built-in visor, if that's how you're achieving your visor. I do think that makes a lot of sense. So that way you would reduce the N95 usage per person down to 1 or 2 per day, depending on whether you're discarding it at lunch or at the end of the day. And then the whole reprocessing, like literally it's like re-sterilizing it. That's the controversy, which we haven't talked about. And how many times you can do that depends on the model and the method that you would use to do it. There is no, all the hospitals are exploring this. We're collecting them, but we're not actually using a re-sterilized mask at this point because we still have new ones to use, and that would be very significantly off-label. But prolongation of the N95, yeah, that I think everybody should be strongly looking at, because there just isn't the supply in the market to be able to change them after each patient.
Yeah, my question was clearly on prolonging, not on reuse. I wasn't going to comment on that.
Yeah, I mean, the reuse is sort of part of it, because if you take it off to have lunch, for example, then you're reusing it after lunch. You've taken it off and you're putting it back on. And so the reuse, you know, there is a lot of literature on that. For example, in non-infectious diseases situations, if you're using an N95 mask for asbestos remediation, you know, there's no issue of touching the surface of the mask and taking it off and putting it back on. You just want to make sure that the outside doesn't get onto the inside. So, you know, there are ways to take off an N95 mask and then to put it back on. I don't know. I mean, we have videos. I don't know if there are videos on the internet. I can describe it in general. Again, I'm not endorsing anybody doing this without actually being trained on how to do it. We'd be happy to try to help clinics with that. But typically you would get like a Tupperware container that is appropriately sized to sort of fit around this part. Can you see? It's a little dark behind me, sorry. The window's making my face dark, but that you would, you know, an appropriately sized Tupperware container, and you push it, because you don't want to touch the surface of your mask. Even though there's a visor, you assume that it's contaminated, but you put the Tupperware over front, so you're not touching the mask, you're touching the Tupperware, and then you would take off the top elastic, take off the lower elastic, and the elastics are sort of on the outside of the Tupperware container. So your hand is here, and then the elastic is on the other side of your hand, and the mask is sitting in the Tupperware container, and then you take it off, and so you have the mask with the inside of it facing up, and the elastic bands dangling down below the Tupperware container. And everyone, are you following what I'm saying, or is that?
Yes.
Yeah.
Okay. And then you can clean the surface of the lunch table, put it down or put it somewhere, and then clean your hands, have lunch, and then pick up the Tupperware from the bottom, which is clean, put it up against your face, and then put the elastic bands on, and so you can wear it again after lunch. So that is the reuse. I think in most hospital settings, people are focusing on prolonged use. I think people have started looking at reuse. If you're going to do it, again, from a Ministry of Labor perspective, if you're going to do something like that, you would need to argue that you've appropriately trained your staff so that they're safe to be able to undertake that that adventure, if you want to call it that.
It makes sense. Thank you.
Another question, Kevin, with regards to office and clinical procedures was we got questions about what products are being recommended for the twice-a-day enhanced office cleaning and disinfection of high-touch surfaces. Wondering if you could comment on any specific products that you would recommend.
Yeah, so this is a coronavirus. Coronaviruses are envelope viruses, envelope RNA viruses. They're not difficult to kill. Any disinfectant, any hospital grade disinfectant won't have a problem killing it if it's used appropriately. So if you were to use a quaternary ammonium product or a hydrogen peroxide based product or a bleach based product, all of those would be appropriate. Healthcare disinfectants need to have a DIN number, a drug identification number on them, so that they're Health Canada certified for healthcare environments. You shouldn't be using, you know, home Lysol sprays or, you know, Lysol wipes designed for home. But if you're using Cavi wipes, Virox wipes, Clorox cleanup wipes, or those types of things, those are all appropriate. The big thing is that you follow the manufacturer's instructions, specifically regarding if they're wipes, you don't have to dilute them. But if you're using an actual liquid product, you need to make sure the dilution is appropriate. And then the really key part is that the wet contact time needs to be appropriate. So the viruses and bacteria are killed by these disinfectants based on the wet contact time. And so if you're using wipes, the reason it's so important to keep the top of the wipes container closed is so they don't dry out. So if you wipe a surface with a wipe, it should be glistening wet, so that it's wet for that minute or 2 minutes or 90 seconds or whatever the product recommends to be able to kill envelope viruses or, you know, bacteria or whatever typically we want to kill all of those different categories. And so a nice glistening wet surface with any hospital grade disinfectant is appropriate. And all of the surfaces that the patient has contacted, anything that the healthcare provider's hands have touched during the procedure, any of the equipment, all of those surfaces should be disinfected between patients. The floors should be cleaned periodically, but it's less of a critical surface. The walls also not important between patients. It's the high touch surfaces, the chair, and all of the countertops and things that the trays touched.
Move on to the next topic, which you've already introduced, this whole idea of the 3-hour delay for operatory cleaning. I was just wondering if Stephen Manor wanted to ask any questions specific to this.
Yes, actually, I know, like you're saying, we already touched upon the 3-hour thing, and this is a really hot topic right now, and it's making a lot of dentists very, very anxious and upset even. From what I hear, and to the point where now there's a very widely circulating petition. I'm not sure if you've seen it or have gotten emails on it, but it's one where it's that the petition wants to insist that Canada-wide, quote unquote, dental practices reopen protocols be evidence-based. And in the petition, they're quoting articles from the Nature Journal and whatnot, arguing, why do we need 2 or 3 hours? Like Saskatchewan or Ontario, when this journal says 10 to 30 minutes is enough. And high volume suction, they're quoting another article, takes care of 96% of the aerosols. In other words, being evidence-based, as if saying perhaps, what we're trying to set as guidelines, or the colleges, maybe we need to argue this. Just not saying I agree or disagree, but to me, guidelines are guidelines there for a reason, for the public, for ourselves, for our staff. For now, from what we know. But how do you comment about this 3-hour, and also as it relates to this petition that is very widely circulated amongst dentists?
Yeah, so I'm not a dentist. I try not to get right into the middle of, I have my own arguments, but this issue, I mean, the issue of the background when I read it was around waiting or needing to be evidence-based. I guess as an outsider on it, looking at it, I would argue that there's not really evidence on either side too much. I mean, they're quoting articles, but I think there's a paucity of evidence on both sides. And so the colleges and the Ministry of Labor and all of the regulatory agencies, I think what they're trying to argue is, and they're invoking probably the precautionary principle when there is not enough evidence to try to err on the side of protecting staff in this case, patients, dentists. I think, there was a couple of articles that were invoked. I'm familiar with many of them that they had referred to. I'm not sure that they directly answer the issue. So, the evidence that was cited doesn't actually answer the question any more than the recommendation, which they're viewing as not being evidence-based in the first place. Just to comment on the 3 hours, I think 3 hours is really assuming very, very, very low air exchanges. And then it also talks about settling of the aerosols. If we're talking about aerosols, just to be clear, that the sentence is not exactly accurate, because either these are the large droplets which settle very quickly based on gravity, or we're concerned about an airborne disease where it's actually circulating on air currents, and you're not waiting for these particles to settle. You're waiting for the air to be exchanged. So, they're sort of mixing just the statement, and it's a minor point. But if it's about the air exchanges, then specifically getting an assessment of the air exchanges and being able to do a calculation of achieving, and they would need to say, do you want to achieve 95%, 99%, 99.9% exchange of all the air in that space? And there are HVAC engineers who can come in, measure the dimensions of the air, look at the inflows, look at the outflows, and tell you that your air exchanges in that room are 5.8 per hour or 12 per hour. And as I said, if you get up to 20 an hour, I'm just using that number because I know the calculation. It's about 21 minutes to get 99.9% air exchanges. And typically the hospitals, we try to get to that level of exchange. So in a normal isolation room, which has now the new design for an actual airborne isolation room is, I believe, 12, and ORs are up at 20. At 12 air exchanges, then we would typically keep the room closed for, I think it's 30 or 40 minutes before no PPE is required. So I suspect this will get refined. Again, I think the different provinces and regulatory colleges are just doing a little bit of photocopying at this point, but I think as they start to bring in some experts to help them revise some of these things, I think some of the principles will become more clear, and it comes back to what we just talked about, things that can reduce the risk. And I think some HVAC and engineering controls will help to reduce the risk. The dental dams, maybe the oral, viral load reduction with oral disinfectants, and all these things put together, including screening for symptoms, hopefully will bring that risk down to, 0 or very close to 0. And then also the prevalence circulating in the community also helps a lot. If you have 30 or 40 or 50% of all your lab tests being positive in March, let's say, and then in July you have 5% or 2% of all your lab tests being positive, obviously there's a lot less virus circulating in the community. And so that's, without the dentist doing anything, if there's 0 circulating in the community, the risk in the dental office is 0, right? So there's a direct connection there.
Okay, thank you, Kevin. And hopefully, I guess when the state of emergency is lifted in Ontario, it'll swing that way, like you're saying, with fewer people being infected. But who knows? I suppose.
Yeah.
Thank you.
So, Kevin.
Oh yeah, go ahead.
So one of the concluding guideline in the urgent care and emergency care guidance that were provided to us was for us to avoid referring to a hospital dental department at this time. I'm just hoping you could just remind our audience why this is so critical for us to keep our patients who have dental issues away from hospitals.
Yeah, well, I mean, I don't think it has anything to do specifically with the fact that hospital dentistry departments are problematic, or this just has to do with what viruses like COVID-19 in a pandemic, what kind of an impact that has on the system overall. And essentially, all of these measures that we're taking as a society in terms of trying to socially distance and trying to bend that curve or flatten that curve. I mean, obviously, we don't want to have individual people get very severe disease. We'd like to reduce morbidity and mortality in society. That's a huge part of it. A large part of how we do that, though, is making sure that the healthcare system is not overwhelmed. And I don't have the curves in front of me, but there's a sort of classic graph that if you actually look at the curves, and if you bend the curve and bring it down, the line that gets superimposed over that is your intensive care unit capacity and your ventilator capacity. So, for example, at North York General, we have 24 ICU rooms. We normally would run, say, 12 to 14 ventilators at a time in an average situation. And part of our pandemic planning is to try to figure out where we can put more ICU patients and more ventilated patients. And so the work that we've done, essentially, we figured out that we can actually care for 50 ventilated patients, even though we only have physically 24 ICU rooms and normally only have 14 ventilators. So, by incorporating all the anesthetic gas machines and by having a stockpile of ventilators and by, ramping down our surgeries so that we can use the post-anesthetic care unit to care for ventilated patients as an ICU, and essentially looking at the whole building and saying, how do we fit these people in and how do we find enough ventilators to take care of them? It is a capacity issue in the system as opposed to trying to prevent the spread. So the hospitals obviously are extremely busy during pandemics, and I assume they're not referring people to the hospitals to try to sort of blunt that additional group, which may be able to be cared for in the community. Obviously, if people need to be cared for in the hospitals are happy to care for them. If they're symptomatic with COVID, it's nice to tell them to tell us before they come, or you to call us and tell us before they come, so that we can catch them at the door and make sure that they're wearing a mask and our staff are wearing the appropriate gear. So I don't know, that anyone would say don't come to the hospital. I think all of us are getting a bit nervous, actually, that that with all this social distancing and closing down of society, that we're sort of reaching the point now where bad things are starting to happen because we've canceled a lot of elective procedures. You know, the gallbladders need to be done, the cancer surgeries need to start resuming, the root canals can only wait so long, and things like that, right? So I guess I would say if they need hospital care, they should come to the hospital for care, whether it's for a dental procedure, an oral surgery procedure, a cancer case, or a heart attack. But I think the root behind all of this is just because the hospitals, pandemics are all about capacity and surges and trying to manage the resources of the hospital with what's coming in. And if you look at New York and Italy, a lot of the deaths that happened were just because there were so many people coming at the same time, all needing the same thing, all needing ventilators, that if you don't have ventilators, you're triaging quite young people to say, oh, okay, over 65, they, you know, the rumor is from Italy, over 65 on a medication is off to the side for no ventilator, just because they had to make some crazy decisions because they didn't have ventilators that were free. So thankfully in Ontario, that hasn't been the case. Yeah, if you need the hospital, I would reach out to the hospital, and we're always happy to help.
Thank you, Kevin. Just like to ask Stephen Menor if they have any concluding questions or comments.
You're on mute.
For me, if I may, I think moving forward, the concern might be because of the limitations with PPE and the resources and whatnot, there might be some offices, some colleagues that with all good intentions say, listen, I've got patients that are in pain I need to see. These are procedures that will be producing aerosols, but I can't get the N95, but I heard of a study showing that there's no difference between a level 3 surgical mask and an N95, and I can put an elastic band around it, and you know what? I'm just going to look after my patient as best as I can. They're going to wipe their hands with alcohol. That's my, you know, that's something I hope won't happen, but I'm worried might be happening. Even though dentists, we want to look after our patients and all with good intentions. But have you heard anything about that, or do you want to comment on that? May sound like a silly question, but this is, I think, what we might be facing.
Yeah, I mean, I think there's a few things woven in there. I think we already talked about, you know, dentists, business owners, and have responsibilities to protect their staff under the Occupational Health and Safety Act. So I wouldn't minimize that. That act actually has the potential to have offices shut down, to have major fines, orders be written. So the authorities definitely take these things very seriously. And, you know, probably 90% of my job over the past few months has been psychologist and trying to manage anxiety among staff. You know, part of that is teaching them how to use the gear properly and knowing what the risks are and things like that. But regardless, there's a lot of irrational fear, and so making sure that your staff are trained and have what they need and are comfortable is hard enough when they actually do have everything they need and are trained and are comfortable. When you start offering them things that, you know, they know exactly what the office down the street is doing, and they know exactly what the hospitals are doing, and all the guidelines are published. So if you're starting to sort of cut corners on that, those staff pick up the phone to Public Health, the Ministry of Labor, and the Ministry of Health very, very quickly. So that's the first thing. I think, you know, the issue of it's not a big deal. You know, some of it may be maybe that they truly don't understand that there are very severe outcomes with the virus, and some people are comparing it to the flu. It's not the flu. It actually is more severe than the flu. I suspect people on the call know that. But the flu, the overall mortality rate is about 0.1%. And I would say that's not even a fair representation, because 0.1% is overall, but the mortality probably up to the age of 60 or 65 is 0. And then the mortality in the elderly is where all of that mortality happens. So 0.1% sounds low, but it's concentrated in the elderly. Whereas this virus has a mortality, depending on which jurisdiction you're in, is somewhere in the 2, 3, 4% range. Some of them are up to 10%. I think that's in systems where their healthcare system's been overwhelmed and they run out of ventilators. It's not that the virus is killing them, so the system's not able to support them. And then if you look at it by decade of life, under 18, no issue whatsoever. They don't, there's 0 fatalities pretty much. At middle age, it's probably say 0.4, 0.5% for my age category. And then as you get up to 80, it's probably a 15 to 20% mortality. And those that are institutionalized, even higher than that. People who are immunocompromised, they're additive. So, this isn't a joke when you start getting into those high negative outcome ranges. And I understand, maybe that they feel that these patients need care and they want to provide the care, and that's that's obviously a positive intention. On the other hand, there's some people who are like, we can't keep our business closed for that long and we need to get it back open. So there's a whole mixture of things mixed in there. I do think, obviously that society and governments and all of us have a role. Dentistry is obviously a critical resource that needs to happen. You can only turn it off for so long, and people actually need dentists and need the procedures that dentists provide. And so the PPE needs to be prioritized within the system to be able to allow these procedures to happen. And dentists need to be equally sensitive to PPE preservation and usage as the rest of the system. So, that's a little bit of a long-winded thing to say. Like, I wouldn't just be a Yahoo and just say, no biggie. Your staff won't show up to work, and they'll probably be on the phone pretty darn quickly. So I think it's better to do planning and just sort of screaming about guidelines or whatever doesn't fix it. I think the whole system is trying to protect dentists and their staff and the patients, and I think trying to work within the system is what makes sense to me, and trying to influence it. And certainly, myself and Maya McGuire, who's my partner in Practice Health Check, our goal has always been to try to get dental practices up to a level where it's safe for the patients and safe for the staff. COVID-19 is just an additional twist in the road in terms of what we've been trying to do. But certainly all of these engineering controls and things like that, this is what we do on the acute care side as well.
Thank you. Thank you, Kevin.
Stephen? Thank you. So, Kevin, you've been so generous with your time today, understanding all the responsibilities that you have the rest of the week. We're very appreciative for your expertise in helping us and our community make sense of the recent emergency and urgent care RCDSO guidelines. Today, we focused on the recommendations for PPE, engineering controls, cleaning and disinfecting our operatories. But also, I think it was a sober reminder of our role as being an integral part of the community to be safe in protecting our staff, our patients, and ourselves. On behalf of Benor and Steve and the whole Dental Community Resource, we're really grateful for doing this for us today. I'd just like to finish up by reminding the audience that we continue to conduct our focus group conversations. Please feel free to sign up. We've been doing this for almost 3 weeks now, and I've really enjoyed the interaction with you at a much more personal level. Please sign up on the link available below the YouTube description, or else on our homepage that looks like this. And lastly, information will continue to be posted on our site, and please don't hesitate to reach out to us via our email at community@dentalcommunity.ca. Look forward to seeing you in a week's time on May 12th for our next webinar, Tuesdays at 2. Please be well and stay safe. Thank you.
My take after watching this is I understand where Dr. Katz is coming from. I believe I understand very well the science of this now. My confusion comes from our colleagues in Florida and even in Alberta have just started to use aerosols without these precautions. And I'm having trouble getting my head around all of that. I think that there is somewhat of a risk, and I understand that Dr. Katz really emphasized that engineering is one of the remedies. And I clearly get the idea how engineering can help us with this, but I'm also holding out hopeful that industry and other solutions will come that may be much more affordable for us, much more well within our realm to be able to solve these solutions. But I think we need to stay aware of them. Minor, what's your take?
Yeah, no, thank you, Steve. I agree with you. I mean, what I would take away from all this is, if I may say, sort of buyer beware, as we've been saying over and over. Social media is you go on social media and word of mouth and talk to colleagues and whatnot, and it could be pretty frightening. But just be careful with what you do and what you plan. Stay up to date with the regulations from our college, because in the end, that's the only thing that matters. Whether I like it, you like it or not, we're all in the same boat. We're all practicing clinicians. So just remember that, sort of buyer beware, and only do what absolutely we're told to do, we need to do for everyone's well-being.
Thank you, guys. It's safe to say that it's really hard for us, any of us, to predict the future. 5 months ago, none of us knew much about the SARS-CoV-2 virus, and clearly we can all appreciate how much its presence has really dramatically changed our lives. We still have a lot of questions at this point in time. We will continue to have questions, and our mandate at the DCR, the three of us and our entire team, is to continue to seek answers, to try to make sense of this in a way that is relatable to all of us who are desperate to get back to some sense of normalcy. It's going to be a new normal, there's no doubt, and our goal will be to continue to try to make sense of the information for you. Thank you, be well, and stay safe.
Bye, everyone.
Thank you, everyone.
Bye-bye.
Be well.